My next speaker, I think we are still running in time, so we will finish at 5:30. Dr. Qazi Zaman has asked me to finish in time because we got 3 speakers who haven't come. I think there's some visa issues and from Pakistan in the last session, so that's a much shorter session. The next person I'm going to introduce, I was quite fascinated to see his profile. He's a young, obviously I will still call Professor Enam very young. He's currently working as Professor of Neurosurgery at Aga Khan University. So that's the place where I came from, and that pulled few strings in my heart. But reading his profile is absolutely fascinating. He's a fellow of College of Neurosurgeons excuse me, in Canada. He's a fellow of neurosurgeons in Ireland. He's a fellow of neurosurgery in USA. I think I've spoken so much. Sorry for that. He's a professor of neurosurgery. Obviously, he completed his training from USA. He has been awarded Doctor or Physician of the Year award in America. He has established Pakistan Society of Neurosurgeons, and very recently, Pakistan government has actually acknowledged the work he has done and awarded him Tamga Imtiaz, which is the 3rd highest rank within Pakistan. So, Professor Enam.
Assalamu alaikum. So, after all those speakers and of all this audience, I'm very humbled. So, I don't think I deserve all that. And my passion is actually neurosciences, not neurosurgery. So, the society that I have formed and I'm really working for that is the Pakistan Society of Basic and Applied Neuroscience. And I don't think neurosurgeons are neuroscientists, and neurologists are not neuroscientists. So, neuroscience is in itself a neuroscience. Anyway, so thank you very much for the energy that I see in here. And Sohail, I don't know what you eat. Do you drink Red Bull? Because I never see you down. And I think the APPS brings this energy in everybody. And thank you very much for inviting me for this thing. And so far, I'm very impressed. So what I'm going to talk about is the quality care for those who can't afford. Well, how do I go? Okay. All right. Arrow down, okay. Oops. Oh. All right. So I just have a written talk over here. So Pakistan's healthcare budget is 1.5%, and the healthcare overall in the world has increased about 300% as part of the GDP. So if you put in inflation, then it has gone about 10 times more than it was about 5 decades ago. So the health cost is increasing. And Pakistan's gross national income per capita is very low, $1,400. Whereas if you compare it to USA, it's $56,000, and UK is about $43,000. The cost of brain tumor surgery in Pakistan is about $6,000 to $7,000. Now compare that with the $1,400 that is the GNI per capita in Pakistan. So with this background information, I would like to tell you about a story that a gentleman came from Gilgit to me. He was not smiley, so there was some issues with his welfare also at AKU, but AKU does provide a lot of welfare to non-smileys as well. He had a GBM. He was 65 years old with a hemiparesis and in a very low mental condition. His son was there with him, who was also a Kashtkar. They had a small piece of land in Gilgit, and they would grow from that piece of land. And I talked to them, and I said that, listen, looks like it's a GBM, glioblastoma. And I was very candid with him. If we do nothing, he will survive probably for 6 months. If we do surgery, and if we do chemotherapy, and if we do radiation, then probably average will be a year and 3 months. So probably we'll gain about 9 months in that process. The surgery will cost you this much. You may get welfare from AKU, but then you have to go through radiation. You have to go through temozolomide, which itself will be about $13,000, $14,000, going up to about $20,000, $25,000. What is the amount of land that you have? He says, well, then we are thinking about selling it, and we may sell it for about 12 lakh rupees, which is about $12,000. I said, think about it. We will give you some welfare, but then for temozolomide, for chemotherapy, you will not be able to afford all that. And then you will be under a lot of debt, and your father will be dead in about a year and a half. So is it really worth it? You have your younger brothers and sisters. And suddenly he realized, and next day he left, understanding all that situation. They went back home for comfort care for his father. Now this problem with quality care, if we call it quality care, because that's the standard that we have put in all over the world. A person that comes in with GBM, you have to have a biopsy, you have to give radiation, you have to give chemotherapy. The problem that is not only in Pakistan. I saw that in USA also, and I was practicing as a neurosurgeon over there. There was this gentleman, he was young, he was 30-something, he was a lawnmower, and he didn't have Medicare because he wasn't old enough, and he wasn't poor enough to have Medicaid. He didn't buy his own insurance, and he came up with a brain tumor. And he came to the ER, but then eventually he was refused any treatment, and he was running around to manage some money to get treated for brain tumor, which would have cost him about $80,000 over there. And I then left USA, so I don't know what happened to that poor chap, but that is stuck in my brain. I also remember that Canada, which provides a very good care of, just like NHS over here, a patient came over from Windsor to Detroit, and that person was going paralyzed because of cervical myelopathy. And I said, why don't you go back over there and get surgery in Canada? Because I see that in your letter it says September something. And when the patient saw me, it was August. She said, well, doc, it's not September this year, September next year. That's when I got an appointment with that surgeon. So there are problems everywhere. So quality care can be an issue, not only in poor countries, in rich countries also. But it is particularly so in poor countries. The quality needs money. So quality can come in cost. But then if you jack up the cost, that doesn't mean that you can produce quality. So what are the solutions that we have? Of course, philanthropy-wise, if you look at Pakistan, Pakistan is one of the countries in the top level in terms of philanthropy. There are a lot of money that is pumped in because I think most of the people don't pay taxes, so they have to somehow pay taxes to Allah or go to do Umrah and all that thing. But then the good thing is that there's a lot of money that comes in, and we have the highest philanthropy in Pakistan. The Behbood Society in AKU, we dispersed about $23 million last year, and this year is going to be probably $26 million, which is about 2.5 Arab rupees. The Indus Hospital, which we have been hearing about, is about $10 million budget in about 6-7 years ago, so probably it's about $15 million plus in the last year. SIUT is about $50 million plus budget. This is all coming from philanthropy. So that's one way of dealing with this issue of providing quality care where it's expensive and people can't afford. The other one is expert, and we heard this morning there are experts like Mamoon. I mean, those experts like those, they are doing such a wonderful job. We need to expand that, bring it to other people, train more people and do that. And then of course we have to have sensibility in what we spend. So we can buy equipments which are expensive, but then we have to use our sensibility in that. So for example, there was this robotic that was bought in one of the hospitals in Karachi. It was overpriced by 3 times, and there was no robotic surgery that was done, and it was there for a long time, about 25 crore rupees. Waste of money. And then we have other things also coming in, like for example, we have actually at AKU, we got some robotics for brain tumors. That is not really a good investment in my mind. And then there are disposables that are very expensive. So I don't know if there are surgeons over here who understand CUSA. CUSA is a machine that liquefies the tumor and can suck it out. Now, the CUSA helps improve the quality of patient care in terms of better, safer resection of tumor. But then each time I use a CUSA, it's about 45,000 rupees. That's about $450. So I can't add that amount to the already such a large amount to each patient. So I'm really, my hands are tied, and I don't use CUSA in most of the cases. At the same time, Indus Hospital, for example, does not have MRI. So we should invest money in that and buy an MRI, which is not that expensive, and use that money. So one has to differentiate between the capital versus the consumables. So consumables are where a lot of money goes to waste, and one should be careful about what we use. Now, the primary care is an issue, and we heard earlier this morning about the extenders of the primary care. That's a system that is, I think, used in UK as well, and in USA, that system is used very efficiently. So we can have those extenders go out and take care of patients. That will be much cheaper. And Indus Hospital actually has started to do that. So they will take care of patients, they will treat the patients, and they will discharge them next day. And then the patients will go home, and there will be extender that will go there, a nurse or a nursing practitioner kind of a person, and they will communicate and take care of the patient, and that is much cheaper. So that's another way of doing it. Telemedicine and Google Glass are something that ties into that. And I understand there was a comment raised earlier about where Pakistan, we don't have basic necessities, and we're talking about telemedicine and Google Glass. But then the same country where we don't have the basic necessities, almost everybody has a smartphone in their hand. So I think this telemedicine and Google Glass kind of things, those technologies, if used efficiently and carefully and wisely, they can cut down the cost also and provide quality care to the patients. Now, what I will talk about now, and that's the main thing, will be a controversial thing. So I think that we have to think about that we don't use the same template that is being used in the West for the patients in Pakistan. We cannot hammer a round peg into a square hole. So the patient that had brain tumor, coming back to that patient, we asked him to leave, or I suggested him to leave, and they did go back home. And I think that was the right thing to do for him. So I have been criticized that, is that ethical? Well, in my mind, is that ethical to overdo things that we do so many times? We operate, I mean, as surgeons, I know that about 30% plus operations are not really needed. And I have realized that once I moved from USA to Pakistan. There's so many spine cases that you used to do in USA, and I really don't think we need to do that. And the ethics, we'll talk about ethics, are we really, there's so much conflict of interest which drives us. I mean, the biggest conflict of interest is a surgeon telling a patient that you need surgery. That's one of the biggest conflict of interest. Have you ever thought about that? Has there been ever a disclosure by a surgeon to a patient, look, I'm offering you a spine surgery, but I will make money from it, so obviously my decision is going to be tainted by that money that I receive at the end. So those are the things that we need to think of. Putting in screws, using robotics. Avastin is a medication that we sometimes use for brain tumors, very expensive, not much effect. Gliadel. The gliadel is a polymer that we implant in the brain. Now that has been shown repeatedly over the last 2 decades that it does not increase your survival by more than about a month. And that thing costs about $11,000. So do we really have to use that in Pakistan? Are we going to gain something? We are going to actually drive the quality of the patient and the family much, much lower. So that's not quality care. And then there was this rage of cage. We were implanting cages in the spine, and now it's over actually. The studies came out that it's not really needed. So there are a lot of things that we do, we learn and we apply it, and we think that this is the right thing to do. As we say that, if you have a hammer in your hand, everything looks like a nail to you. So that's the attitude that surgeons particularly and the doctors use all the time. So we need to be careful about that. This picture that I have over here is by Sir Luke Fields, and it was done in 1891. And this is one of the most popular painting, the name of the doctor. And what it exemplifies is the stoicism that doctor has over there, right next to this child who is probably about to die, because in the background, Sir Luke Field is when he painted this, his son had died a few years ago before that. So this is quality care. But the problem in Pakistan is that we just saw one of the slides where there were loads of people outside the outpatient ward. Can you provide this quality care to 150 patients in a day? No, you cannot. So the quality care does not require high cost items. It does not require following blindly the templates, the guidelines, the recommendations that come in from developed countries. We need to think about it. We need to do research. We need to figure out what is the best way of dealing with the problems that are within our own country and what are the resources that we have for them. That's what I wanted to say. Thank you.
We have time for questions. Please. Professor Bilal.
So my name is Bilal Ahmed. I'm a professor of medicine, and I head the Department of Medical Ethics and Palliative Care at a university in America. I think a glaring deficiency in Pakistan is end-of-life care and palliative care. And I'm struck by how, number one, is the non-availability of end-of-life medications in a hospital setting or outside. And number two, I try to start some departments, maybe APPS can be used as a platform, is that the population is just not ready for that kind of a discussion. So once you start those discussions, is either aapki kya dushmani hai patient ke saath, or you have some ulterior motive in this thing, and the patients actually blame you for giving up. So I don't know what your experience is and what we can do as a group of physicians to kind of start palliative care and improve the services that we have in Pakistan.
So it's all cultural and educational basically. Culturally, we are not really open to these things. For example, in Pakistan, we have had only 5 live transplants. Sorry, 5 cadaveric transplants so far. Only 5 cadaveric transplants in the whole country. So people don't understand these things, and when it comes to end-of-life care also, it's the same kind of a cultural attitude. But then what I found in the last 12 years in Pakistan is that actually if you sit down with the patient, you talk to them, they are as open and as intelligent as anybody can be, as I found in USA. It's just that we probably don't know how to explain to them, and we don't give them enough time. But if you do that, I haven't come across a barrier. The only time I've come across barriers is that when I was in a rush. You know, I would like quickly say things that this is how it was done, the operation went okay, and they would say, "Sir, khatare ki baat to koi nahi thi na?" And you know, I grab my head. I mean, the patient had a brain tumor and he is hemiplegic, khatare ki baat kyun nahi hogi? So those kind of things do happen, but then if you sit down, give time to them, explain to them, there's not a problem. So I think what we can do is that raise the education level, raise the rationality in the society to understand these things, so that each doctor doesn't have to, and each doctor is not prepared and trained to do that. So when they come in already trained and educated with that concept in their mind, they will perceive whatever you want to tell them much faster.
Thank you very much.
Thank you.
Thank you, Professor Enam.